Hi, everyone. My assignment today is to talk about utilization of the gap analysis and establishing the measurement for strengthening your AMS program. With that, the objective of my 30-minute talk also would include first, I would like to share with you the AMS consensus in Asia Pacific. And then I would like to introduce you to the gap analysis and the example of the utilization of the gap analysis. And the last part, I would like to talk about how to define appropriate measurement for AMS program. With that, I would like to start that in Asia Pacific, there are some gap that is quite common in this region, including the lack of epidemiology data and the lack of awareness in AMR, the weak infrastructure, the insufficient education and training of hospital staff, limited funding, and prescriber resistance to AMS program, as well as poor infection control that I consider are very common gap and challenging in implementing AMS program in Asia. With that, the suggestion of the consensus all included that you should have the team. The team should consist of the core team that most of the time should include infectious disease that act as a team leader. The clinical pharmacist should act as a co-leader, and also the clinical microbiologist who can provide the diagnostic support, and infection control expert who can provide infection control support, as well as the information technology expert who should provide information technological support. And of course, the responsibility has been listed in this PowerPoint. In addition to the core team, you should have the supportive team that most of the time should consist of the hospital administrator, nurses, and other physicians that involved in the team, particularly the surgeon and the physician that involved in some agenda of the AMS team that target in your institution. After have the well-established team, the next part is to think about having the outcome and process related measurements. And the example of the process related measure may include the antibiotic consumption like the DDD or DOT that I will share with you in the next slide, and also the appropriateness of therapy, where the example of the outcome measure may include the infection related mortality, the antibiotic toxicity, the cause, the incident of MDR bacterial infection and colonization rate. The next part that I would like to share with you is the gap analysis. And to perform the gap analysis, I suggest you to look at this article and you get into the supplementary tool. You can find the gap analysis. The gap analysis has been broken into many parts, including the hospital leadership support, AMS team and infectious disease training, AMS program intervention, AMS monitoring and reporting, hospital infrastructure, and education, where the C represents core component and S represents supplementary component, where you have to fulfill the C first, and then you can do the supplementary component. But in some cases, you may have some partial supplementary component establishing in your institution already. So the way you do the gap analysis is that you just checklist in the gap analysis. For example, for the question pertaining to hospital leadership support, does your hospital have financial support? Yes or no? You just check yes or no. Or does your hospital allocate budgeted financial support? Yes or no? And you just check yes or no, and etc. You do it for all components listed in the gap analysis. Once you have do it, the summation of score will be broken down into the core component and supplementary component, and the total score sum up at the 39 score, that a summation of the core and supplementary score listed in here. After you perform the gap analysis in the supplementary, there's a way to help you to overcome the gap and challenges. For example, the question related to the hospital leadership support, if you check no to both C1 and C2, the flow will suggest you to prioritize getting formal support and approval from hospital leadership for AMS activity, and also to provide hospital administration with a credible business case to persuade them to funding for AMS program that is beneficial to the hospital. And these has been broken down in many components that you can just follow the flow to help fix the gap, to overcome the gap and challenges in your program. The gap analysis can be used to help grading and analyzing the gap in the network. And this is the example of the gap analysis on AMS program in Central Thailand within our network. And as you can see here, once we broke down with the gap analysis, we can find that only 60% of the network had the C-score fulfilled, but none had fulfilled all S-score component. Only 34% received financial support from hospital administration, which means that almost 70% did not get financial support for hospital AMS program. For the core component, microbiologists, clinical pharmacists, process and outcome measurement, regularly published antibiogram are lacking, where the S component, the lack of IT support for AMS, the lack of treatment and surgical prophylaxis guideline, and the lack of unit-specific antibiogram, and the lack of monitoring for process and outcome are commonly reported. And you can use these to strengthen the program in your network as well. The use of gap analysis can be used to analyze strength of the network in international as well. And it is the study had just recently performed in 10 Asian countries and analyzed the core component. And as you can see here, the core component has been practiced in this region somewhere from 50% to 90%. And in brief, most Asian hospitals participating in this survey still fell short of international gold standards, and thus inter-country differences in gap may highlight that country-specific solutions are needed to improve current standard for AMS program. This can be a helpful tool to help strengthen the program in your hospital, in your network, in the international network as well. The next part that I would like to share with you is to select appropriate measurement for your AMS program. But before saying that, I have to say that defining and implementing stewardship metric is very complex, because in general, when you see the infected patient is already complex, because the patient always have multiple components that involve noise, decision making. The patient safety outcome and resistant infection are infrequent sometimes and have multiple confounding factors as well. The significant effort are required to extract metric for antimicrobial stewardship for what? From medical record, and for what? For complete meaningful analysis. And then what should we do to translate analysis into actionable conclusion? And this is the principle why we defining and implementing stewardship metric. Thus, category of outcome metric and process metric should include antibiotic use measurement, that most of the hospital will select either DDD or DOT, that I will share with you in the next slide. Second is the quality measure. For example, the compliance with the guideline, the use of the care bundle, the appropriateness of therapy, the critical outcome and safety measure, including the length of stay, mortality, toxicity, readmission, and lastly is the cost of antibiotic acquisition cost. The total cost of care are included in the cost metric as well. As a matter of fact, there are some discrepancy between the practice and perceived importance of each metric. And this is the study that performed in the United States, that they put the metric that listed in the outcome metric box, like antibiotic use, cost, appropriateness of antibiotic use, and etc. And they asked many people, including the hospital administration, pharmacy director, ID physician, and P&T committee. And interestingly, everyone value the metric differently. For example, if you are ID physician, they would value infection-related mortality and appropriate antimicrobial use as being the most important one. If you are PT committee, antibiotic use, appropriate of therapy should be the top one for them. But if you ask the hospital administrator, they would say cost only is the most important one for them, where the pharmacy director may value antibiotic cost and antimicrobial use as an important metric. So really, who are the boss? Who do you want the data to convince is very important to collect the metric appropriate to those people as well. But not all the metrics are evidence-based. There are some metrics that has been extensively studied and can be readily used as an evidence-based things. For example, the incidence of Clostridium difficile, MDR, incident and day of therapy, and etc. While there are a lot of metrics that still need ongoing study to confirm the value of this metric, including the antimicrobial error, the toxicity, the time to appropriate the therapy, the escalation, and etc. that listed in this PowerPoint. The most widely used metric of antimicrobial use is DDD and DOT. The DDD defined daily dose, which was recommended by WHO, which is the average maintenance dose per day for a drug use for its main indication in adult, and then it's calculated by determining aggregated grams of antibiotic purchased, dispensed, or administered, and divided by WHO assigned DDD value, where the DOT was used by CDC for reporting antimicrobial use, calculated by tallying number of calendar day during which a patient received an antibiotic-based or administration data. And then the denominator, most commonly used one, is the patient day or day present that accounted for the partial day as well. There are some pro and con for each metric. For example, the DDD advantages, it does not require administration data, but the disadvantages is that it may not appropriate to use in pediatric population and in renal impairment population as well. DOT, while the advantages include is not affected by discrepancy between WHO assigned DDD or those used in practice, but it requires administration data, which may be difficult to obtain in all institutions. So obviously, there are some limitations for each of them. The limitation of DDD and DOT may also include it does not directly measure quality, process, and clinical outcome. And in certain situations, the decreased antibiotic use, particularly decreased DDD or DOT, may not be inappropriate or harmful, and it may not adequately adjust for the case mix, severity of illness, antimicrobial resistant prevalence as well. So we also need some alternative metric to measure DSP performance in addition to DDD and DOT as well. But before I talking about the additional metric, we need to understand what will the metric be used for. In some institutions, the metric may be used for external benchmarking. In some, it's only using for internal benchmarking. In some institutions, it may need to help guide for specific intervention that you perform. And justification for your ASP program, what does your leadership see as important, as previously slide that I shared with you, and you should know the metric that impact the payment of your hospital as well. And for other purpose that you want to select additional metric to measure the program. So one size may not fit all. But the big four or critical outcome metric that commonly used in the ASP include first mortality, mostly infection-related mortality if you can collect this data, length of stay, infection-related length of stay or readmission, incident of Clostridium difficile, and antimicrobial resistance, which all metrics are important and should be monitored. But having said that, each metric also have its own limitation as well. I will share with you one by one. The first one being mortality and length of stay. The advantages is that the metric has been monitored and valued by clinician, patient, public administration, and it can be captured routinely on all patients. And in some institutions, if you see a high mortality, you can use this as a measure to improve the safety and the outcome, including if you use it with integration of the rapid diagnostic to optimize PK/PD approach, it can help you to optimize the patient outcome as well. But the limitation is that the major issue is the confounder and competing risk because infection is very complicated. Sometimes it has a lot of confounder as well. It's very complicated to determine independent impact of antibiotic and the outcome. And when there's success, many services will claim the credit. And also it is very difficult to use to measure the impact of day-to-day intervention as well. But having said that, it's good for specific intervention, but ASP should avoid relying on them routinely as a sole or single metric to use. The incident of Clostridium difficile, the PRO has been has been widely recognized as an important stewardship metric. It has been widely used in the United States and has been extensively studied. But the limitation is that the control require not only antibiotic use, but it also require effective infection control program, where sometimes the community colonization and community pressure of the C. difficile has been high, and sometimes institutions use different C. difficile detection testing. Thus, it is an important metric and important to recognize its limitation at the same time. The next metric is the MDR pathogens. The advantages of MDR pathogen is that it's gained a lot of attention in the healthcare, government, and the public. And antibiotic use impact MDR, as you may know, and in many cases, and some MDR are publicly reported in some countries as well. The limitation is that the control, similar to Clostridium difficile, require infection control, and sometimes community rate colonization in the community is fairly high as well. And also the impact of stewardship in some MDRO are relatively low. So you have to select appropriate MDR as a target for stewardship as well. The type of MDR where ASP matter most likely came from the pathogen that occur in the hospital, including the hospital onset Acinetobacter, hospital onset Pseudomonas aeruginosa, particularly the resistant one. The CRE antibiotic may play an important role in the emergence of this pathogen, and it has been recognized as a threat by CDC and also WHO as well. The incident and rate influenced by other factors than ASP. But as far as MDR go, ASP has a major impact on these, and therefore they might be the most appropriate to use as a metric as well. A new era of antimicrobial stewardship may target upon some MDR metric, and this is an example of direct measurement of the key performance towards some gram-positive, like anti-MRSA, anti-VRE, carbapenem as a metric, and also the incidence of CIE can use as a metric, as well as the antimicrobial resistant hospital onset of Pseudomonas and Acinetobacter can be used as a metric for ASP program as well. Important metric that commonly overlooked is toxicity and adverse effect. This is commonly overlooked as a metric, though optimal dosing, avoid unnecessary therapy, in theory, can decrease toxicity. The clear example is the use of vancomycin. If you use a trough-based strategy and AUC-based strategy, the study has been shown clearly that the antibiotic exposure has been significantly less in AUC-guided dosing strategy comparing to the trough concentration guided dosing. And these translating into significant less toxicity comparing the AUC to trough-based strategy in the study. But in reality, implementing effective vancomycin dosing strategy may require multidisciplinary team to support to improve hospital-wide adherence with vancomycin dosing protocol. And it is the example in my hospital where multidisciplinary team, including infectious disease, clinical pharmacists, and ASP team try to convene the vancomycin dosing protocol. The result is that we are able to achieve significant adherence as well as reduce significantly 30-day mortality in the patient as well. This is the example of the outcome that we use to monitor for vancomycin dosing strategy using AUC per MIC strategy during the post-intervention that we implemented multidisciplinary team. It can help reduce, it can help improve the appropriate loading dose, the time to concentration, appropriate adjustment and monitoring, and also it can help reduce significantly 30-day mortality as well, where the multidisciplinary team is a predictor for reducing 30-day mortality and improving adherence to vancomycin dosing protocol as well. Other quality measures are important to use if you want to select to use, including appropriateness. It is difficult and labor intensive to assess true appropriateness because you have to measure with the treatment guideline that exists in your institution, and also the number and proportion of ASP recommendation that has been accepted. You have to stratify based on the empirical, definitive, and also duration of therapy as well. The process, although easier to measure, a surrogate measure for appropriateness of care, including the clinical indication, appropriate use of diagnostic, and use of form to measure the compliance of the program, etc. Appropriateness of therapy can be defined into many components, including the redundant of therapy, initiation of therapy for some indication that may not need antibiotic, like asymptomatic bacteriuria, and appropriateness for empirical therapy that should be consistent with the guideline and target some key important indication like bacteremia. And also definitive therapy and the de-escalation is an attractive one to use that can be integrating with the rapid diagnostic test as well as duration of therapy that has a strong evidence base for some common infection as well, and relatively straightforward metric to obtain. The new era of the AMS program should integrating the rapid diagnostic into it as well. This is the data in Asia Pacific that suggests that the rapid diagnostic for AMS program has a key its key important use in 3 time frame. The first time frame is the initiation stage. that the objective of this time frame is to determine whether antibiotic is required, if antimicrobial is appropriate, to determine which one should be used, like antibiotic or antiviral. An example is very clear. The test for COVID, the test for influenza, the use of procalcitonin to distinguish viral and bacterial infection. The use of rapid diagnostic can be used in the ongoing stage, including to facilitate targeting or broadening of therapy. And the example of this test, including the molecular testing, respiratory and GI panel, and also procalcitonin test as well. And the last one is the de-escalation and cessational time frame, where the use of rapid diagnostic can be used to help facilitate early IV to oral switch to facilitate de-escalation or cessation of antibiotic. And there are a lot of tests, including multi-TOF, lateral flow assay, and procalcitonin to help you both de-escalate or cessational of antibiotic. But in reality, there are some challenges to overcome to integrating rapid diagnostic in AMS in Asia Pacific. The key challenges may include the insufficient funding, the inability for some RDT platform to accommodate full range of organisms, the lack of microbiology lab with sufficient expertise, and suboptimal patient care pathway and reporting structure, as well as the lack of the national guideline and general guideline to help endorse this is a key barrier as well. In conclusion, I would have to say that the gap analysis can be used to improve the quality of AMS program, to understand what you want to measure and why you want to measure, and the goal of intervention should help determine metric use as well. Utilization and cost metric are important, but not necessarily reflect quality and appropriateness. Mortality, length of stay, causative difficile, MDRO are important outcome metrics, but are influenced by factors other than antimicrobial stewardship. But don't forget about toxicity and safety as well. And lastly, appropriateness of prescribing is important, but can be resource heavy. Consider redundant of therapy, compliant with empirical therapy guideline, and duration of therapy for study as well. With that, I would like to thank you very much for your attention. ขอบคุณครับ